The learning objectives of this lesson includes the following. First, derive knowledge of anatomy and physiology. Second, obtain healthy history about respiratory system. Third, demonstrate physical examination, which is the most important in our lessons. And the last, differentiate between normal and abnormal findings. As we know, the breathing consists of two cyclic phases. The first phase is inhalation, also called inspiration, which draws gases into the lungs. The second is exhalation, also called expiration, which forces gases out of the lungs. The primary structure of the chest is designed to facilitate ventilation, which can be accomplished only by increasing the intrathoracic volume, and the human respiratory system include trachea, bronchus, and alveoli. And the lower respiratory system includes the right lung and the left lung. As shown in the figure, the right lung is divided into three lobes, upper, middle, and lower, and the left lung is divided into two lobes, upper and lower. And the structures of the chest wall includes ribs, pleura, muscles of respiration are also essential. Each lung covered by one pleura. The parietal pleura attaches to the walls of the pleural cavity, and the visceral pleura adheres to the surface of the lungs. There are pleural fluid fills and duplicates the space between the parietal and the visceral pleura. Each successive rib is very important to help pulls on the neck via intercostal muscles. When ribs move up and out, it moves like bucket handles, and the volume of thoracic cavity increases. So what happens when volume increases? Then the pressure decreases, air gets sucked in. As shown in this figure, during the phase of inhalation, the rib cage expands and the lungs expand. Diaphragm contracts downward, then the volume increases and air moves in. During the phase of exhalation, the rib cage contracts, lungs compress, diaphragm relaxes upward, and the volume decreases, air moves out. The physical examination begins with the commencement of history taking. The healthy history includes any risk factors for respiratory disease, smoking, such like how many packs per year, how long time exposure to smoke, how they attempt to quit, what was the method to quit smoking, and what was the result. Sedentary lifestyle, immobilization, the age, how old the patient is, the environmental exposure to the dust, chemicals, asbestos, and the air pollution, if the patient got the problem of obesity or not, and the family history. If the patient complains about the coughing, which we need to know the type of the cough, dry, moist, wet, productive, sounds hoarse, hacking, pucking, or whooping, and the onset of the cough, the duration of the cough, the pattern of the cough, the accompanying activities, the time of date, and the value, and how the severity of the cough. If the cough accompanied with wheezing, and if there are any associated symptoms with the cough, and do they have already get the treatment, and how the effectiveness of the treatment. If the patient got sputum, we would like to know the amount, the color, the odor, the consistency, and the pattern of the production, and which is important also if there are any presence of blood in the sputum. The history determines the examination format. Experienced clinicians exploit the history to help them look for specific physical findings to answer questions posed by the totality of data collected previously. By the time the physical examination is complete, even before laboratory evaluations are initiated, the diagnosis should be reasonably certain. When the history initiates suspicion of the presence of a chest problem, the physical examination of the thorax must be expanded beyond a minimal screen examination to determine the nature of the problem, so that a diagnosis can be met. Then come to the physical examination. The pulmonary examination consists of inspection, palpation, percussion, and auscultation. During the physical examination, the setting must be environmentally comfortable for both clinician and patient. Patient should sit upright on the examination table, and the hands should remain at their sides. When the back is examined, the patient is usually asked to move their arms forward, like to hug themselves position, so that the scapula are not in the way of examining the upper lung fields. And the lighting should be adjusted so that it's easier for clinician and the patients, not too strong and not too weak. and the chest should be fully exposed. The exposure time should be minimized. A stethoscopy is needed for auscultation. Inspection is an active process. It is done with the eyes and the intellect. It begins with the initial greeting and continues uninterruptedly during the entire physical examination process. Specifically, one must note the dynamics of the patient's facial expression in relationship to physiological activities, inspiration and expiration, and to the questions asked by the examiner. Similarly, active observation skills are used to search for the use of pursed lips during expiration, the activity and development of the chest muscles, the use of other accessory muscles of ventilation, the flailing of the nasal, ala, and so on. It's especially helpful to make an initial assessment of the ventilatory pattern. Specifically, one should be concerned about rate, breathing volume, and apparent effort associated with breathing. Most resting adults breathe about 12 to 20 times per minute. In the newborn, about 44. Women slightly higher than men. The ratio of the respiratory to the pulse is normally 1 to 4. Tidal volumes range around 600 milliliters. Except for an occasional sign, the normal ventilatory pattern is regular and effortless. In disease, this pattern may change. The respiratory rate may decrease in restrictive disease with emphysema and pneumothorax, and the respiratory rate is more than 20 cycles per milliliter, which call as tachypnea. In emphysema, the alveoli at the end of the airways in the lungs are damaged, and the sacs become larger. In pneumothorax, the air enters the pleural space, either by a hole in the lung or the chest wall. Thus, the pressure in the pleural space equals to the pressure outside the body, which results as the lung collapse. The respiratory rate may increase, but tidal volume typically remains unchanged. The presence of slow, gasping ventilatory maneuvers is an ominous sign suggesting cerebral hypoxemia. The respiratory rate may decrease with sedation. The rate is less than 12 cycles per milliliter, which is called as bradypnea. Hyperpnea, named as Kussmaul breathing, present with deep, regular sighing respirations. The breath volumes are then increased without substation modification of rate, whether the rate be normal, slow, or fast, as a compensatory mechanism to ground the effect of a metabolic acidosis such as occurs with uncontrolled diabetes. When this occurs, the effort associated with this Kussmaul breathing seems to be minimal. The shallow breathing, named as hypopnea, present as the decreased depth of breathing, which may occur in decreased medullary respiratory center drive, weakness of the respiratory muscles, or loss of alveolar volume from any cause. This rhythmic breathing is typified by Chernus Stokes respiration. The pattern results from cyclic hyperventilation, followed by compensatory apnea caused by phase delay in the normal feedback controls, which maintain a more constant pressure of carbon dioxide. This apnea refers to a periodic pattern of alternating hyperpnea and apnea, though at times it's a normal phenomenon seen in infants, the elderly, and during ascent to altitude. More often, it is a reflection of significant cardiac and/or pleural nervous system dysfunction. Palpation is the next stage of the physical examination. It includes 4 steps: tracheal alignment, excursion of thorax, vocal flumitus, and pleural flexion flumitus. A part of the palpatory portion of the chest examination is to assess the position of the trachea. This is accomplished by palpating the anterior inferior neck just above the jugular notch, by gently placing the fingertips between the lateral tracheal wall and the medial portion of the sternocleidomastoid muscle. Comparing one side to the other, an assessment is made of the position of the trachea, midline, or deviation away from the centrist position. Any deviation of the trachea is abnormal. Deviation of the trachea to one side can mean that a process is either pulling the trachea to one side or pushing the trachea away. The pulling process, such as the loss of lung volume, atelectasis, fibrosis, agenesis, surgical resection, or pleural fibrosis. The pushing process, such as the space-occupying lesions, pleural infusion, pneumothorax, large mass lesions. Any mediastinal masses or throat tumors may keep the tracheal still in the middle position. Let's have a look for some abnormalities of tracheal alignment. First, pneumothorax is kind of pushing process, shifts the trachea to the unaffected side. Pleural infusion is also a kind of pushing process, shifts the trachea to the unaffected side. Fibrosis or atelectasis is kind of pulling process, shifts towards the affected side. Pulmonary consolidation can be bilateral, that the trachea can be still in the middle position, no shift happens. Palpation is also important in the assessment of ventilation. One can sensitively assess the semen nature, synchrony, and volume of each breath. This is done by pressing the examiner's thumbs together at the midline and let the palms move free with the chest when the patient inspires deeply. For the upper thorax, the examiner places a band on each side of the patient's neck with palms against the upper anterior thoracic wall. The upper forelibs move forward with inspiration. Then extend the thumbs so the tips meet in the midline. For the anterior middle thorax, place your fingers high in each axilla and your thumbs abduct. Move the hands medially, dragging skin to provide slack until the thumb tips meet in the midline at the level of the 6 ribs. For the posterior lower chest, we need to have the patient sit or stand with his back toward us, and then place our fingers in each axilla with the palms applied firmly to the patient's chest, so our forefingers are 1 or 2 ribs below the inferior angles of the scapula. For the costa margins, with the patient supine, place our hands so the extending thumbs lie along the interior edges of the costa margins, with the tips nearly touching. Both visual and tactile observations are met both during tidal volume breathing and during deep forceful inhalation. When the upper forelibs move forward with inspiration, then our thumbs diverge from the midline, typically separated by approximately 2 to 3 cm. Assessment of ventilatory excursion includes evaluation of the synchrony of expansion and the degree of chest expansion associated with a deep forceful inspiration from residual volume. Asymmetric expansion invariably implies decreased ventilation to one side, either associated with structural immobility or defect, or pain. Similarly, the problem may be caused by an inflamed, fibrosed, or malignantly infiltrated pleura, an urinary pleural infusion, or a complete obstruction of an airway or airways on the ipsilateral side. Vibrations transmit to the surface of the thorax as upper airways sounds are generated by breathing or speaking is a traditional through insensitive manual referred to as tactile or vocal flumitus. The process of vocal flumitus assessment starts to ask the patient to say 99 or 1 to 3 several times in a normal voice, and we can palpate using the bar of our hand, and then we can feel the vibrations transmit through the airways to the lung. Sequence for examination of the chest is from anterior, lateral to the posterior sequence. For palpation, place the palms of the hands in a position designated as 1 on the right and left sides of the chest. Compare the intensity of vibrations and continue all positions in each sequence. After bilateral comparison of vocal vibrations, diminish or absent of vocal flumitus indicate the increased distance between lung and chest wall, such as thickened pleura, pleural infusion, pneumothorax, atelectasis. An increase indicate alveolar consolidation, such as pneumonia or inflammation. For the assessment of pleural flexion flumitus, we use the same method as vocal flumitus, but at a spot where the patient feels pleuritic pain, and it occurs when inflamed, unlubricated surface of pleura rub together during respiration. The sensation of the feeling is like 2 pieces of leather being rubbed together during the respiration. The pleural flexion flumitus may disappear when the patient holding breathing. It indicates cellular exudation in pleura due to pleurisy, such as tuberculosis, uremia, pulmonembolism. Percussion is a major aid in the assessment of ventilatory excitation, the assessment of hyperinflation, and the presence of vocal thoracic disease. The directory percussion or immediate percussion is to elicit sound by striking the body surface directly with our fingers, hand, or reflex hammer. It's not commonly used, but can be very rewarding. Indirect or mediate method is commonly used to place the distal fingernails of the middle finger firmly on the area to be percussed, and rest the second and fourth fingers off the chest surface. Otherwise, both sound and tactile vibrations will be blinding. We use a quick, sharp wrist motion, like a catcher throwing a baseball to second base, to strike the finger in contact with the chest wall with the tip of the third finger of the other hand. The best percussion site is between the proximal and distal interfingeral joints. The novice quickly learns to trim the fingernail to prevent personal discomfort of minor abrasions and lacerations. If the sound and vibrations produced seem suboptimal, make sure that the finger pressed directly on the thorax is making very firm, direct contact with the chest wall. If not, few vibrations and little sound will be produced. Percussion the anterior, lateral, and posterior chest wall in such a manner that the long axis of the percussed finger is roughly parallel to the ribs, and compare one side to the other. Over each area, begin percussion superiorly and extend inferiorly to identify the level of the diaphragm during quiet breathing. Note the position of the diaphragm. Then ask the patient to inhale fully and hold it. Continue to percuss inferior to determine the new level of the diaphragm. Now, during Fox muscular inspiration, then don't forget to tell the patient to breathe normally. The difference between the two levels is known as diaphragmatic excursion and should equal 2 to 3 cm. The orders of percussion is normally from up to down, from the anterior to the posterior. Non-abscess, named also as cornice ischiums, is the narrowest part, lies on the shoulder top. We use commonly the direct percussion in the lung abscess. For the anterior lungs, we doing the percussion downward to the region of hepatic ductus on the right and the treble semilunar space on the left. For the posterior lungs, the patient's arms are folded in front, like hump the shoulder. Then the percussion of each hemithorax is begun at the top, working downward to compel symmetric regions sequentially. Lung sound in percussion is resonance. There may have slight dullness in some areas, such as the upper, right, back, due to the thickness of muscles and skeletons. The purpose of percussion is to determine if the area under the percussed finger is air-filled, sounding resonant like a drum, or fluid-filled, like a dual sound, or solid, sounds like a freak sound. To make this interpretation, it is important not only to listen for the sound produced, but also to feel the intensity and frequency of vibration produced by this maneuver. The general percussion over a hemithorax can give a clue as to the presence or absence of a pulmonary process. When the percussion note is hyperresonance, one can postulate that the lungs are hyperinflated, such as may occur with emphysema or during so-called air trapping seen in patients with acute asthma. This may also occur in patients with an acute spontaneous pneumothorax. Dullness to percussion, particularly associated with the presence of a high, poorly moving diaphragm, is likely to be associated with a restrictive ventilatory defect if the findings are bilaterally symmetric. Usually, this is associated with an interstitial pulmonary process that can be further evaluated by the presence or absence of late inspiratory crackers on auscultation. Flatness to percussion suggests the virtual absence of air directly beneath the percussed finger and may reflect either fluid in the pleural space, such as pleural infusion, emphysema, solid material in the pleural space, fibrosing mesothelioma, or atelectasis. And the tympani in state of resonance may indicate pneumothorax. The posterior lung basis is aimed to assess the shifting range of bottom of lung. It indicates also the expansion. The process of posterior lung basis is along the scapular line, first percussion bottom of lung and marking, then asking the patient to inspire deeply and hold, and then percussion the bottom of lung, marking again, and then asking the patient to inspire deeply and hold, then percussion the bottom of lung and marking. Lastly, to measure the distance between the upper and the lower lines, the decreased posterior lung basis indicate emphysema, atelectasis, fibrosis, pulmonary edema, and pneumonia. If it's impossible detected, it indicates pleural adhesion, massive hydrothorax, pneumothorax, and diaphragmatic paralysis. The normal shifting range of bottom of lung is 6 to 8 cm. Auscultation, as a more sensitive process, confirms the earlier findings and may help to identify specific pathologic process not previously recognized. Auscultation of the chest, ideally, is performed in a quiet room with the patient either sitting or standing. It is not only intuitively obvious, but rigorously proved that the intensity of breath sounds is related to flow rates. That is, the louder the sound, the greater the flow rate, all other things being equal. Thus, to assess the breath sounds, ask the patient to breathe in and out slowly and deeply through the mouth. It is not suggested to begin at the apex of each line and zigzag downward between intercostal spaces. Listen with the diaphragm portion of the stethoscope. The orders of auscultation is usually from up to down and from the anterior to the posterior. When the posterior thorax is examined, the patient's arms should be closed anteriorly to move the scapulars laterally as much as possible. Comparing one side to the other is a helpful manual to identify the patient's normal. Auscultation should be performed during the tidal ventilation, the deep forceful inspiration and expiration. Generally, the information from the auscultation is provide the normal breath sounds, the note, pitch, intensity, quality, and the duration. We need to identify the normal breath sound from the abnormal breath sound and ventilative sound and the vocal resonance during the auscultation. Vesicular sounds are thought to be produced by gas movement through the distalmost portions of lung units. They are low in pitch, predominantly inspiratory in timing, and have a breathy character. Bronchial or tracheal sounds are produced high in the upper airways and trachea. They are often loud and high-pitched. The expiratory phase is longer than inspiration and follows a silent gap. Bronchial vesicular sounds are intermediate between the two. Under normal circumstances, air-filled lung units act as high-frequency filters so that the bronchial breath sounds generated in the upper airways are poorly transmitted through air-filled lung. On the other hand, when there is little air-filled lung between airways and the stethoscope, or when lung units are filled with liquid rather than gas, bronchial breath sounds are heard clearly. As a result, bronchial breath sounds are heard normally over the tracheal, the upper sternum, and paraspinal areas of the upper thoracic vertebrae. As one moves periphery, and more air-filled lung is found between the airways and the stethoscope, breath sounds first become bronchial vesicular sound in quality and eventually vesicular breath sound. The bronchial breathing, named also as tubular breathing, could be result from consolidation or compression of pulmonary tissue. It demonstrates a short inspiratory phase and a long expiratory phase. The bronchial vesicular breathing could indicate a small degree of pulmonary consolidation or compression. The two respiratory phases in bronchial vesicular breathing are about equal in duration. The vesicular breathing as a shallow breathing by having a long inspiratory phase and a short expiratory phase are heard normally almost over the entire lung surface. The decreased or disappeared vesicular breath sounds may imply the weakness of respiratory muscle, the obstruction of airway, the hydrothorax or pneumothorax, the abdominal disease such as ascites, large tumor. The increased vesicular breath sounds may imply the stronger movement of respiration. There are three types of abnormal breath sounds. Frequently, they are collectively referred to as adventitious breath sounds. Moist cracks, launch, pleural friction rub. The major reason of the moist cracks is airflow passes thin circulation in the airway to rupture the pulse, or to open the cracks of bronchiole due to adhesion by circulation during the inspiration. The cracks resemble the sound of several hairs being rubbed together between thumb and forefinger. It occurs in pneumonia and pulmonary edema. The mechanism of the launch, or named as dry wells, is that the turbulent flow is formed in tracheal bronchiole or bronchiole due to the airway narrow or incomplete obstruction. Thus, the causes, including the congestion, secretion, spasm, tumor, foreign subject, or compression. And the diagnosis depends on the site of the launch. If it's both fields, it may imply for asthma or chronic bronchitis. If it's the local site, it may imply for the tumor or tuberculosis. Auscultatory visits imply the presence of slit-like openings through which a critical velocity of gas is passing. When visits are local, one must consider external compression of an airway, enlarged lymph nodes, and tumors to this. Diffuse wheezing is present in inflammatory process, such as bronchitis, both acute or chronic. Contraction of hypertrophied bronchial smooth muscle as seen in asthma. It's not equal to obstructive airway disease. The assessment of the pleural friction rub is the same as the palpation, but the auscultation is more sensitive. That's all for today's lessons. Hope it's helpful for you to learn the physical examination of lung and pleural. Thank you for your listening.